Hey guys, so my post was talking about the vestibular function in the inner ear, how that helps us maintain our balance, and how when things go wrong with this particular function, how vertigo occurs and the particular management that happens when patients have vertigo. So, okay. So the first part is basically talking about where is the vestibular organs. And so what we see here is that on the ear we've got the external ear, we've got the middle ear, and the internal ear. And the vestibular cochlear organ over here lies within the inner ear. Okay, so if we zoom in onto it, what you've got is two main structures. You've got the semicircular ducts, which are we've got three of them, 1, 2, and a 3. You've got a cochlea, which is involved in hearing, and also a third part that is over here. So the utricle and saccule. So this whole segment over here, the semicircular ducts and the utricle and saccule, are in charge of your balance as well as positioning, whereas the cochlea over here is in charge of hearing. There are some important structures of this part that you may need to know of. One is that it is surrounded on the outside by a bony labyrinth. Within it is the perilymph, and further inside is a membranous labyrinth, and then you can see filling the membranous labyrinth is this thing called endolymph. So you've got perilymph on the outside and endolymph on the inside. This is quite important as to how these structures detect whether if you're upright onto the side, and we'll go through how that occurs. The semicircular ducts, so you've got 1, 2, and 3, there's 3 of them, and they have 3 different names which we'll go through, and they also have these little bodies inside them which we'll also go through as well. Okay, so next slide. So the next part is we're going to zoom in now onto the semicircular ducts. We've got 3 main ones, as I mentioned: the anterior, the posterior, and the lateral. And what we've got, so I'll just go through what they do, is these guys are important in sensing the direction and the strength of a particular, so the direction that a person's moving their head or the whole body is moved in. So if we zoom in on one of these structures over here, which is called an ampulla, so this section is called the ampulla. If we zoom in on it, so what you've got here is this thing called a cupula, and attached to the cupula is attached to these hair-like structures, which is bound to the wall, is called the crista over here. And each of these hairs is linked to a sensory nerve. So what happens is that, let's say if you turn your head, when you turn your head around, the lymph, the endolymph on the inside, this blue stuff, is going to flow alongside the direction of the movement that your head made. And what that's going to do is, let's imagine that the fluid is moving in this direction. It's going to knock onto the structure over here, and you can see when the fluid rotation is in this direction, this is going to cause the structure to move from its straight point, and that's going to trigger the hair cells to send the brain a signal saying, hey, there's this movement in this particular plane. And at rest, the hair cells don't move because the endolymph isn't moving at all. And this concept of how this movement or detection of movement occurs is quite important in later on figuring out why vertigo occurs. So keep that in mind. So interestingly, what happens is that if you shake your head as if you're saying no, then that is the lateral semicircular duct that is being affected. Nodding your head in a yes-like position is going to cause the anterior semicircular canals to activate, and if you tilt your head from side to side, as if placing your shoulder to your ear, your shoulder to your ear, or ear to your shoulder, that's the posterior semicircular canal that is, and the structures within it that is being affected. So, moving on to the utricle and saccule, so that's these guys over here. Just then we went through these three ducts. The utricle and saccule, they are quite important in determining and providing sensations of gravity and linear acceleration. So what that essentially means is that they determine whether if you feel that you're standing upright or upside down. Because notice that with these guys over here, I just mentioned that if you were at rest, then these hairs won't be activated. So at rest, these guys work when when you're actually doing something or moving around. But whereas these guys over here, they're quite important to tell you what position you're in, even when you're at rest or you're not moving. So how they work is that instead of these, you can see from the diagram over here, instead of these shaped looking structures over here, the maculae, or so that what these structures are called within the utricle and saccule, look quite different, and we'll have a look at zoom in on what they look like. So what you've got, similarly, you've got these hair follicles as well, hair cells, and they're also attached to neurons and nerves that go to the brain. But on top of it, you can see over here is a gelatinous material. And on top of that is statoconia, or these little calcium, I think they're calcium carbonate crystals. And so what they do is they provide a bit of weight and they sit on top of this gelatinous material. Together combined, the gelatinous material and the statoconia, together they're called the otolith. And how they work is that when you're standing upright, the gravity works on these crystals, because it provides a bit of weight, and it presses down on the gelatinous material, presses down on the hair cells, and that sends a signal telling your body that, hey, the gravity is working in this downwards direction, so odds are you're standing upright. But if you tilt your head back, then these otoliths will be pulled towards the direction that is still gravity's directly down direction, but since it's but this time, since your head is tilted, the gel also moves in a posterior direction as well, and so it affects. You can see that the hair particles over here are different, and that's going to send a different signal. So you can tell that even at rest, because of the structure of the otoliths, you can tell what kind of position your body is in. So that's how they work. And what happens to these kind of signals? So you've got all of the hair follicles have nerves that lead to this thing called the vestibular ganglion. And these nerve bundles send messages into the midbrain. So just let me check. That is, they send it to a vestibular nuclei at the boundary between the pons and the medulla oblongata. So they go from the vestibular ganglion along the vestibular branch into the boundary between the medulla and the pons. What happens is that you can see that this vestibular branch is part of the vestibular cochlear nerve, or nerve 8. That's the one responsible for hearing. Cochlear branch, I believe that's the one that would be involving in hearing, but yeah, that's the vestibular branch and the cochlear branch fusing together to make the vestibular cochlear nerve. So the 8th cranial nerve. And they have a few functions, but to keep to the topic, what is quite interesting and I think is quite important to know is that this thing called nystagmus can occur because of nystagmus is a particular problem that can occur when things go wrong with this particular system. So one thing you need to understand is that there is an automatic movement of the eyes that can occur due to the vestibular branch. And how that is that these signals that tell your body what kind of position or what type of acceleration your body is undergoing helps you lock your eyes on a particular object whilst you're moving. So it's an automatic kind of reflex. And as you can see, the signals go down here and they hit the nucleus and they get sent off to different parts. And I've highlighted some of the important ones. So they can go to the oculomotor nerve, trochlear nerve, and abducens nerve. So that's 3, 4, and 6. And if you think back to your cranial nerves, these guys are important in eye movements. So, and how I think it works is that the automatic movements of the eyes are in response to the sensation of motion that's directed by the superior colliculi. That's these two guys over here. So they're directed by the superior colliculi of the mesencephalon. So, what nystagmus is I think what it is that it's a rapid eye movement, or twitching of the eyes when the body is at is supposedly in a still at rest position. And so you look in the patient's eyes and they're at rest, but for some reason when you tell them to fix their eyes on a certain point, their eyes kind of flicker while it shouldn't. And so what it suggests is that there's nystagmus occurring because there's some abnormal signals probably that's being sent to the midbrain and the superior colliculi over here, and it's telling the eyes to automatically lock on to, or changing the position of things for the eye to lock onto. However, whilst in actual fact nothing is actually happening. So that is my interpretation of how nystagmus occurs. And with all that in mind, now we can start to tackle what vertigo actually happens, what vertigo actually is. So the definition of vertigo is that it is an illusion of motion, or most commonly is a rotary sensation that is occurring when the patient is standing still. So because it's an illusion of motion. In addition to this, what you can have is sensations of nausea, vomiting, sweating, or pallor. This could be due to a few reasons. One is that there is a lack of function with the vestibular system. An example is vestibular neuritis. Another example is hyperfunction. There's too much signal that is coming from that area. An example we'll go through is benign paroxysmal positional vertigo, or they abbreviate it as BPPV. It could also be due to a central neurological disorder, so something wrong with the brain affecting vestibular pathways. One of the most common reasons are migraines, and other than migraines, these guys are actually quite a rare occurrence. So, what we've covered is that means that there could be a central reason, something that's due to the brain to cause the vertigo, or it could be something that's peripheral, something due to the actual structures that is actually leading to vertigo. So one of the ways you can differentiate central or peripheral vertigo from each other is the addition of different symptoms or features. For peripheral, one of the more common ones is that you can get a bit of hearing loss, ringing of the ears, tinnitus, and oral fullness. Okay, so one of the most common reasons for acute vertigo, so something that has spontaneously occurred and is very disabilitating or severe vertigo to the patient, is a vestibular neuritis. And I believe herpes virus, I think, has something to do with it. The treatment for it is prednisolone. And commonly, for all of the different types of vertigo that we're going to mention, there's a symptomatic management of vertigo, which you can use these following medications to try and treat them. So the bracket 1 here indicates first line, bracket 2 means second line, and one of the most common ones you'll see in Australia is prochlorperazine, and that's the dosing of it according to the therapeutic guidelines in Australia. It's a dopamine antagonist, and its brand name is called Stemetil. Alternatively, you could try an antihistamine called promethazine or Phenergan, and they can help with the symptomatical management of dizziness caused by vertigo. However, it's best, according to the guidelines, to actually treat the disease rather than have long-term symptomatic management, as some of these dopamine antagonists particularly can cause a bit of drug-induced Parkinsonism because it plays with the dopamine pathways, or diazepams, benzodiazepines over here. Long-term use could possibly lead to dependence, so it's not recommended for these guys to be used long-term. It's best to find the cause and treat the cause. Okay, so with recurring vertigo, so just then we went through acute vertigo. Recurrent vertigo, one of the more common causes is Meniere's disease, where inside the endolymph compartment there is a buildup of fluid, and that causes vertigo. You also have tinnitus, oral fullness, and hearing loss that occurs. So just a quick recap, it's the endolymph compartment, so this blue compartment over here that's being affected. The management for Meniere's disease, in a nutshell, is a symptomatic management for each time you use it after the attack, so that's these guys over here. And then in addition, you can have a reduced salt intake plus a diuretic, such as hydrochlorothiazide, to reduce the fluid buildup in the area. And you can use this thing called a vasodilator called beta-histine, or the brand name is called Circ, that is commonly used as a preventative medication to treat Meniere's disease. And then finally, we're going to go on to motion-induced vertigo. So this is a completely different cause as to Meniere's or the other ones we've discussed previously, and this one's called benign paroxysmal positional vertigo, BPPV. And what happens is a crystalline deposit actually displaces from the utricle matrix and lodges itself into the posterior semicircular canal. And what that essentially means is that there's an excessive response to head movements. So what I'll show you is just that it said it was the utricle, and so they have these little calcium deposits, or these things called otoliths, that actually dislodge and they go into the posterior canal. So you've got something that's stuck within the posterior canal. Usually at rest, the endolymph in the blue part over here does not move at all. However, and so since they don't move at all, these structures over here, they won't wiggle and wobble, so the person won't feel dizzy, or because you don't feel anything, you're not moving. However, when you do have some of these calcium deposits, the otoliths, stuck in here, even when you're not moving, these can float around and disturb the fluid movement in here and cause these guys to wobble and shake because of this disrupt structure. And so they mentioned that it's particularly common in the posterior semicircular canal. And so when in certain particular head movements, that would cause the patient to become a bit dizzy. So, one of the ways to diagnose BPPV is the Hall-Pike maneuver, and practitioners who perform the Hall-Pike maneuver, if you watch the video, go to YouTube and search up BMJ Hall-Pike maneuver, it's particularly interesting, but you can see that to me it seems quite dangerous, and you need to be trained in how to do this, because you might hurt the patient's back. And I think that's one of the contraindications that practitioners need to be aware of if the patient has particular neck problems or back problems. What you're going to do, from what I've observed, is that you look at the patient's eyes and you look for any wobbling or shaking, so i.e. the nystagmus, and then whilst you have their head tilted in a certain direction, you suddenly just drop them, or carefully lie them down, and that will aggravate the semicircular canals, or the the particular stones in the semicircular canal to aggravate those particular movement sensing structures, and that would cause or recreate a bit of nystagmus or dizziness. And that's what you're trying to do with the whole pipe maneuver. And how do you actually manage BPPV is that you can use these different types of maneuvers over here. A Semont maneuver, Epley, or Brandt-Daroff exercises. These are not medications, and interestingly, these are physical maneuvers that you can get the patient to do to try and actually get that stuck calcium deposit out of the semicircular canal, so out of here and back into the utricle over here. So it displaces it and chucks it out somewhere else. And they actually work a lot better than drugs that are used for symptomatic management, because after all, the symptoms won't really, if you treat the symptoms, the dizziness, that doesn't get rid of the cause of the actual stone stuck in the semicircular canals. So yeah, you can have a look. I've got the links up here, so you can have a look at YouTube and see how you actually perform these maneuvers. And I thought that was particularly cool. So yeah, so that's all. We've gone through how the vestibular function works, what are the structures, what is the nerve conductions. We've gone through what vertigo is, and we've gone through quite a few types of vertigo and their management. Thank you for watching.